let's understand a little bit about polyploid versus flat dysplasia. So in this schematic diagram, I show you a few scenarios. Just for argument's sake, this is somebody who has not pancolitis, but extensive colitis, or left-sided disease. Now, if somebody is found to have flat dysplasia in an area that's been involved with colitis, especially if it's multifocal, nobody likes to play with that. We usually take out the colon for that indication, do a colectomy. The flip side is this scenario, where somebody has a polyp that might even be in an area of inflammation, or certainly if there's a polyp outside of an area that's never been inflamed, we believe those are true adenomas. I mean, an IBD patient is entitled to get a sporadic adenoma, right? I mean, they live in the United States. The incidence of adenomas is 20, 30%. Why can't they get one? And we do believe that these are standard adenomas. And we just remove these endoscopically and go home. The big controversy has really centered around these two types of lesions. So one lesion is still called the DALM. This is a very difficult term to get your hands around because it means different things to different people. Dysplasia-associated lesion or mass. And it's, it's kind of like, if it looks ugly, it is ugly. If it's lumpy, bumpy, and if it has ill-defined borders, but most importantly, if you can't get that out endoscopically with assurance, we call that a DALM, and that is something that usually should go to colectomy. You can't endoscopically resect it. Now, for years, we used to send these patients to colectomy also. These were polyploid raised lesions that came back. It could be low-grade, could be high-grade dysplasia, and everybody freaked out because we didn't know if there was dysplasia anywhere else. There's now data to show that if you have a polyploid lesion even in an area of inflammation, but you can get it out, if it looks like an adenoma, you can get it out endoscopically, and you biopsy throughout the rest of the colon and there's no dysplasia, these people can continue to remain in surveillance. And that was probably the most important concept to emerge in the last 10 years in this field. So what does it look like? Yes?
Before you go on, if you can go back one slide.
Mm-hmm.
I'm just curious, sometimes we talk to our fellows not just about removing that adenoma-like DALM, but then doing biopsies all around the base to see if there's any evidence of dysplasia at the base. Is that something?
I'm glad you brought that up. That's exactly right, because you don't know if this is that unless you biopsy the base. So we never biopsy the base of a sporadic adenoma, so it's not in our consciousness. But if you have a mass or even a small little bump, in fact, let me show you on these endoscopic photos. So this is somebody with flat dysplasia. You can't see it. I can't see it. If I put some chromo in there, I probably could. This usually goes to colectomy. This is a polyp in the right colon of somebody who's only had left-sided disease. This is a sporadic adenoma. Take it out, go home. This is a DALM, okay? It's ill-defined, it's velvety. Jerry Way would probably chip away at this and think that he's, curing the patient, but most mere mortals who can't do colonoscopy would send this patient to surgery. But this little bump here, we would take that out. Of course, we'd find out only 3 days later from Henry that it's dysplasia, but you have to biopsy around the base of this thing to make sure that there's no dysplasia there or elsewhere in the colon. Because arguably, even if there's no dysplasia right at the base of this, if you do your every 10 centimeter 4-quadrant biopsies, you might find dysplasia somewhere else. So this summarizes what I've said. You can keep people in surveillance as long as the polypectomy is complete, the base of the biopsy is biopsied, and there's no dysplasia anywhere else in the colon. And there's been some nice follow-up studies from Rob Odds' group and Peter Rubin and Dan Present's group at Mount Sinai. So we like to think of things going in a normal, natural progression. Of course, with sporadic adenomas, we know the Vogelgram. With IBD, we'd like to think that you go from no dysplasia, just colitis, to indefinite, to low grade, to high grade, to carcinoma. And it's a nice model, and we like to use it. It's not absolute, as you know. You can go from low grade to cancer. You don't have to pass through high grade dysplasia. It's not an absolute progression. I won't have time to go over some of the molecular changes, except to just highlight briefly, as you can see, that some of the changes at the molecular level are very different. The same kinds of changes occur. So microsatellite instability can occur, aneuploidy can occur, P53, APC, but the sequence of events is often different. And that's, I think, where biomarkers really could come in handy is if we can identify markers of colitic and not yet dysplastic mucosa to see who's going to go into this progression at all. Because I think with healthcare dollars being so scarce now, it would be also useful to identify a low-risk group, the 85% of people that are never going to get cancer. We're scoping them every year right now because we have no idea, who's going to get cancer or dysplasia. Let's understand the natural history now of dysplasia. Starting with high-grade dysplasia, this again is based on limited evidence. So if you look at the literature that has looked at surveillance programs and took individuals who went to colectomy only because high-grade dysplasia was found, there was no cancer obvious to the endoscopist. If a colectomy was done immediately, meaning within the next few months of the finding of high-grade dysplasia, about 40 to maybe 65% of individuals will have a surprise finding of a cancer in that colectomy specimen, even though it wasn't seen endoscopically. Now, granted, these numbers are small, and granted, a lot of this literature is based even on fiber optic colonoscopies, which we laugh at now, but some of it was still video. It's not high def. But these are the numbers, okay? So, and if you wait, if you say, okay, I'm not going to operate right away, I'm going to wait for some period of time, the risk doesn't go down all that much. So for high-grade dysplasia, and I should qualify this and say that this is in flat mucosa, because if it's in a polyp, even if there's high-grade dysplasia, just like with a sporadic adenoma, if you take a sporadic adenoma that has high-grade dysplasia and you've gotten the whole thing out, patient is cured. We believe the same thing happens here. If it's high-grade dysplasia but in an endoscopically resectable polyp, that's fine. You can keep the patient under surveillance. But if there's high-grade in flat mucosa, the colon really should be coming out. And not too many studies sit on these patients, so we don't really know the natural history of high-grade dysplasia beyond too much period of time. The real controversy is centered around low-grade dysplasia. This is the same analysis. If you look at the surprise finding of cancer when a colectomy is done only for low-grade dysplasia, you find about a 20% surprise cancer rate in those colons. And if you wait, and I'll show you the next slide, it doesn't go down all that much. So again, numbers are small, but it's from different medical centers, it's reproducible. So there is a surprise 20% cancer rate if you operate only for low-grade dysplasia. Now, is that okay? Well, a lot of times patients don't want to have surgery. They want to wait. Here's what happens if you wait. There's 4 studies in different parts of the world that say if you wait over the next 5 years after you found low-grade dysplasia, your chances of getting cancer or high-grade dysplasia, this slide groups them together, you may have as much as a 23 to a 54% progression to high-grade or cancer in the 5 years after finding low-grade dysplasia. So that's a formidable risk. However, there's just as many studies that say that the risk is much lower. In fact, here's 35%, but it took 20 years to get there. Or here's no progression after 18 years. So again, doctors, patients are trying to grapple with this. And what do? It's interesting, but Corey Siegel just had a paper that came out in the IBD journal, I think last month, where he asked patients who had IBD and said, what degree of cancer risk would you accept to go for colectomy? They said, doctor, you have to tell me that I have a 73% chance of a cancer being there for me to lose my colon. A 73, for us, 20% is scary, but nobody asked the patients. So now Corey went back and said, okay, what degree of risk would you accept? And when it's your butt on the line, I guess it's got to be 73%. So it's an interesting thing. I think we have to always factor in the patient's acceptance.